I think it's easy to set up. I've taught many of my techs and nurses on how to set up the device, and many of them have actually gotten back to me telling me that it is one of the simpler devices to use. They're able to essentially carry out the whole procedure with me, helping me with setting it up and then cleaning the device. So we do feel that it's very maneuverable in the cath lab.
You don't have to do anything other than opening the box, connecting the battery, and then passing it over the wire. And you, as a proceduralist, are in total control of where the cutting is happening or where the debulking is occurring. So I feel like this is a very easy device to use.
You do have to kind of understand, how to rotate the head of the device to go after the plaque, whether it's medial, lateral, anterior, posterior. But in today's vascular surgery practice, I think that the techniques that the fellows are graduating with and that we use on a day-to-day basis, this device doesn't ask you to do anything that you're not already utilizing in your skill set on a day-to-day basis.
I've used orbital atherectomy in addition to directional atherectomy. How it compares, I would say the learning curve of Hoque is probably a little bit more, but I personally like the results of directional atherectomy a lot more. I find it more consistent, more reliable. So that's why I tend to use directional atherectomy.
I have been asked whether number of passes matter or not for the outcomes. Actually not. It's the result of achieving less than 30% stenosis in the vessel. If you obtain it with one pass, that's enough. But if you need to do more than 5, 6, or even 8 passes to achieve it, I would continue to go forward in doing that.
Using atherectomy devices in general will add more time to your procedure. However, you're actually achieving better lumen gain and potentially decreasing the chances of dissection, and hence decreasing the need for stenting, and subsequently patient developing in-stent restenosis.
Historically, before, when I was utilizing rotational atherectomy, you'd have to maybe get a small head through the lesion first, followed by a larger diameter bit. Whereas now with directional atherectomy, I'm already there. I can focus my atherectomy on where the pathology is, and I don't have to change devices. I don't have to switch anything about the Hoque device itself. I can rotate it, cut, and then carry on with my procedure.
It doesn't add a tremendous amount of time. In fact, most of my cases are less than 45 minutes. It's absolutely worth it because the patients see the results, you see the results, and people that you're working with, your referring physicians, will see the results.